Hello and welcome back to yet another episode of the Nabi Journal Club podcast series. I am your host, Dr. Raghav Shrotriya. I am a senior consultant in plastic surgery at Medanta Hospital, Gurgaon. And today we have with us Dr. Kuldeep Singh, who is a well-known plastic and cosmetic surgeon working as a senior consultant in aesthetic, plastic and reconstructive surgery at Indraprasth Apollo Hospital, New Delhi. Sir has a number of publications to his name, including various chapters in textbooks on burns and aesthetic surgery. He is a master trainer in injectables and a faculty of various cadaver anatomy courses. He is on the editorial boards of many national and international journals, and his areas of interest are early surgery in burns, non-surgical facial aesthetics, cadaver anatomy for injectables, and lasers in aesthetic practice. Sir is a well-known face in the burn academic circles and is commonly seen participating in discussions and debates related to various academic matters in the burn meetings. I welcome you, sir, to the podcast.
Thank you, Dr. Raghav. It's a pleasure to be here today.
Thank you, sir. The topic of our discussion today is this paper, Laser Treatment of Specific Scar Characteristics in the Hypertrophic Scars and Keloids. This is a systematic review published in the Journal of Plastic, Reconstructive and Aesthetic Surgery, Volume 74, in the year 2021. The authors are Oosterhoff, Beekman, Vanderlist and Nielsen from University of Amsterdam in the Netherlands. Now, before we go on to start the podcast, our objectives here are twofold. We want to learn about using the lasers in the burn scars, and also we would like to learn a bit about how to do systematic review and how to publish it. So let us start with the paper. Hypertrophic scars and the keloids cause severe physical and psychological problems in the patients. And since the laser is a recent treatment option for the scars, a wide number of lasers are available. Starting with the eligibility criteria, this study was conducted following the PRISMA statement. Now, PRISMA is Preferred Reporting for Systematic Review and Meta-Analysis, which is the reporting guidelines for doing the systematic reviews. Now, the inclusion criteria were in vivo clinical trials, cohort study, and case series, which had at least 5 cases studying the effects of laser therapy on the hypertrophic scars and keloids. If multiple therapies were studied, the papers that included a study arm utilizing only the laser therapy were included. No publication date restrictions were there. Also included were the patients of all ages with hypertrophic scars or keloids of at least 6 months of any etiology having received laser treatment therapeutically with a single laser. Exclusion criteria had studies containing patients receiving additional therapy either concomitantly or previously. The primary outcome measures were mean improvement and response rates, while the secondary outcomes were independently described scar characteristics like pain, pruritus, erythema, etc. Now here we can see the information sources and search strategies for the papers. So this is the search algorithm as given in the paper. Sir, here I would like to ask you if you can help me make head or tails of this.
So, basically 3 databases were searched: PubMed, Embase and Cochrane Central. And the keywords which were used were either cicatrix or hypertrophic or keloid or excessive or scar and treatment or laser or therapy. So these were the keywords used so that you could get all studies or case reports related to these keywords.
So the titles and abstracts were then reviewed independently by 2 authors for eligibility, and in the case of disagreement they were reviewed by a third author. So here I would like to point out that the author roles have to be defined earlier, and it is a very important part in the study design. In the data collection process, one reviewer extracted the data of the included studies, and the collected demographics included scar age, patient age, skin type, number of patients and gender, and laser treatment specific points like laser type, laser settings, and the total treatment. Here we see the quality of individual studies which had to be evaluated. So this is the pyramid showing the level of evidence with the expert opinion at the bottom, and in the increasing sequence we have case series, case reports, then case control studies, then cohort studies, then randomized control trials, and the highest systematic reviews and meta-analysis. Sir, I have never really understood what is the difference between systematic reviews and meta-analysis. Could you shed some light on that?
So a systematic review is to analyze all data available on that topic or study parameter.
Right.
And it is good if you include only RCTs, because then a systematic review of RCTs is the most robust form.
Mhm.
And you find out what was the analysis of those studies and what is the conclusion of those studies. Meta-analysis, and meta-analysis defined as analysis of analysis, uh, takes a specific question of evidence, and you see various studies which have studied that question, and then you find out the significance of answering that question, whether it was there or not there. Like, for example, in a meta-analysis regarding albumin use in burns, whether survival in patients receiving albumin was better or those not receiving was better. So it answers a specific question.
Mhm.
So that is the difference between a meta-analysis and a
So
systematic review.
review is kind of a study of studies, and meta-analysis is analysis of analysis.
Absolutely. Meta-analysis may be part of a systematic review, but
Right.
not the other way around.
So for evaluating the quality of our studies, in this paper, the authors have used two instruments. One is Miner's instrument, that is the methodological index for non-randomized studies. So this is for the non-randomized studies, and there's another one, Pedro scale, for the randomized control trials. We don't need to learn this, but we need to be aware that such instruments are available to evaluate the quality of the studies being included in the systematic review, and the robustness of our systematic review will depend on the quality of these studies.
So one thing I wanted to say is that today a lot of software is available, AI is available for help in conducting systematic reviews. On the University of Maryland website, there is a page which shows exactly how to conduct a systematic review, and for each step, what software is available. So you can go there and use that particular software to get through a certain stage of your systematic review, for search, for analyzing, for assessing the robustness of the data. So you have software for everything, and there's AI research, and it's available there on the University of Maryland website.
So that is definitely useful for people who want to do the systematic reviews. Next, we come to the statistical analysis. The primary outcomes were reported as the mean, and the secondary outcomes were the scar characteristics were compared amongst themselves. So here we see the study selection flow diagram. This is generally the first slide of the results in any systematic review. Here you can see from the top to bottom the way the papers were evaluated and included in the study. So you can see that the authors started with 1676 papers, and out of them, a lot of them were excluded based on the language, the study designs, the availability of full text. And finally, they ended up taking only 30 papers and included them in this systematic review. What would you like to say about the quality of studies?
So, level 2 evidence, we had only 10 studies which were prospective randomized control studies, whereas we had 20 studies which level of evidence in which was level 3 and 4, and they were mostly retrospective studies. So retrospective studies have a lower level of evidence as compared to prospective and random. You can see here that there's also a large heterogeneity present, like in parameters studied, like skin type, etiology, location, the type of laser used, the settings used. So there is a lot of heterogeneity. So that will be a limitation in this systematic review.
Here we see that the Miner's instrument was used in 26 studies, and the Pedro was used in evaluating 4 studies. Now the mean score for the Miner's was 8.3, while the maximum is 24, which is almost 1/3 the way down. And the mean Pedro score was 6.75, and the maximum is 11, which is almost halfway down. So this tells us about the overall quality of the studies. Coming to the study characteristics, the total number of patients in all the 30 papers was 833. 65% were females, 29.2 was the average age. Going by laser type, the number of studies that included these lasers has been shown, and number of treatments were anything between 1 and 12. The follow-up was between 3/4 of a month up to 12 months. Sir, what would you like to say about this?
So if you see the number of studies per laser, so there were 6 studies which studied fractional CO2 for scars, 2 studied argon, 5 studied erbium YAG, and PDL was studied in 14 studies. So you have enough studies to evaluate the fractional CO2, erbium YAG, and the PDL.
Out of the 30 included studies, 20 reported observed subjective clinical improvement values. To evaluate the scars, various type of evaluatory methods were used. Now, Vancouver scar scale was used in 14 studies, while the POSAS scale was used in 2 studies. Here you can see that the VSS had a reduction in the post-treatment mean score as compared to the pre-treatment mean score, which is the good thing. The lower the score, better is the scar. And same goes for POSAS. The post-treatment score was lesser than the pre-treatment score. 13 studies with 16 study arms reported the outcomes on the scar characteristics were identified. Total reported outcomes was 48, out of which statistically significant were 23, non-significant were 10, and p-value was not reported by 15 reported outcomes. So what would you like to comment on this?
So this only shows that 1/3 of the studies, statistical significance was not done. And that reduces the robustness of these studies which are included here, because statistically significant p-value will definitely increase the credibility of that study.
Coming to the laser specific results, here we see the effect of various lasers on various scar characteristics. That is erythema, pigmentation, height, and pliability. So here we see that fractional CO2 laser has a higher score than the overall mean in all the departments of erythema, pigmentation, height, and pliability. So would you like to comment something on this?
So you can see that fractional CO2 was the most effective laser here as far as overall improvement in a scar characteristic is concerned.
If we discuss the effects of laser, all the scar characteristics, the erythema was reduced by 50% in ablative systems and reduced by 26% in the PDL group. Now, the PDL is supposed to be good for the highly vascular and erythematous scars, but this was not supported in this study results. So, why do you think was this case?
See, because number one is collagen remodeling caused the major part of impact, and PDL also does not have a very good penetration. So maybe surface vascularity may be temporarily decreased for some time, but unless you actually remodel the scar vascularity overall will not go down. And hence you see that PDL alone did not have improvement as much as the ablative lasers had.
Right. In terms of pigmentation, minimal changes were seen across all results. That means no laser was found to be very effective in the pigmentation. Scar height was reduced remarkably in all the arms, with CO2 fractional lasers showing the best reduction, and reduced pliability corresponding to the signs of tight scars. There was a slight advantage of CO2 laser as compared to the other lasers.
So CO2 laser you will see will produce some improvement in the tightness of the scar, especially where you don't see much of contracture, just tightness of skin. There you will see a CO2 laser will benefit.
So based on this study, the authors have come up with this algorithm according to which the clinicians can decide on which laser to use for which scars. So for a erythematous scar, the preferred is, and the moderate effect will be of the PDL. For a pigmented scar, the preferred will be a CO2 laser. For a heightened scar, again, the preferred one will be a fractional CO2 and erbium YAG, followed by PDL, which has a moderate effect. And for a rigid scar, the preferred one is fractional CO2 laser, and PDL and erbium YAG have moderate effect.
So here you will see that by rigid scar we mean which is stiff and which is now not erythematous. And you will see that the preferred laser there will be a carbon dioxide fractional laser. It will make it more pliable, flatter, softer.
So this is an algorithm that can be used by clinicians for deciding on which laser to use where. Next we come to the limitations of this study. No level 1 studies were used in this review. A statistical meta-analysis between the treatment modalities was not feasible because of heterogeneity in the laser treatment regimen. Now regarding the treatment response, the results varied widely because of probably the follow-up times, and this study aimed to evaluate the specific scar characteristics, but almost half of the studies did not include the scar characteristics. The studies generally did not report the frequency and type of adverse events. Most studies scored the scars only by subjective and not by objective scar scales. So more should have used VSS and POSAS. Sir, what do you think about the limitations that have been mentioned by the authors?
So what happened is in these studies included is they were so heterogeneous. Some included different duration of scars. For some, follow-up time was different. Some did not specify detailed characteristics. Some did not use any of the validated scales. So the ones which use validated scales are more robust, and therefore it is good if you include most of the studies using validated scales, then that data is more reliable.
So the authors conclude that multiple factors can influence the choice of treatment: physician experience, treatment availability, patient's knowledge, the size of the region to treat, the area of the region of the scarring. Now, this systematic review suggests that the ablative fractional CO2 laser yields the most improvement across all scar characteristics, and the algorithm that has been illustrated can be used to guide clinicians in choosing the treatment. So, do you think there is anything else that we can get out of this study?
Yeah, also it can guide future research. We know the lacuna in the existing studies. We know which parameters have not been studied. We know that robustly designed studies were not there. So anybody who is interested in the effects of lasers on scars can now design a very robust study.
So, in the context of the laser treatment for burn scars, we have included two more papers. So, here you can see this is a randomized control trial from Australia in which the authors have described ablative fractional CO2 laser on a 3-month-old scars. It is a cohort of 14 patients, and evaluation has been done by VSS, POSAS, and RNA sequencing analysis. They concluded that early CO2 laser administration modulates burn scar evolution and impacts patient-related outcomes, scar appearance, and fibroelastic activity. So, what would you like to say about this study?
This has always been a question as to how early can you start laser treatment. And there were, before this study, mostly late studies done 6 months later, 1 year later.
Right.
So they did the study 3 months post healing, and they wanted to see whether there is a significant change by one sitting of laser in the POSA scale, the VSS, even the RNA sequencing analysis, and they found that the RNA sequencing changes, they lasted for at least 3 months, and they found improvement in almost all aspects. So this only showed that you can possibly start treatment early and you can modulate the scar better.
This is another case series from Australia, and it included the use of fractional CO2 along with intense pulse light in 31 patients having hypertrophic scars, and evaluated the changes in scar using POSAS before and 6 weeks after the laser treatment. And they have showed that laser plus IPL single treatment is effective in hypertrophic scarring. Sir, what was the context of this study?
There are studies which have evaluated fractional CO2. There are studies which have evaluated other lasers like the erbium and the IPL. The IPL was very often used for pigmentation, but there was no study which used a combination of fractional CO2 and IPL. So they had two study arms. One study arm was only treated with the carbon dioxide fractional laser, and the other study arm was treated by a combination of fractional CO2 and IPL. They wanted to see what is the difference. They found that all parameters improved in both groups, but it was significantly more in the combination group.
So it might be a good idea to include.
To combine, yes. Okay. But again, you have to see that the CO2 laser, because of its wavelength, is colorblind. It does not influenced by the Fitzpatrick skin types. Because it passes through the epidermis freely. But the IPL, you have to be careful. If you are having skin of color, then you have to use filters which will allow only wavelengths above 1200, which the IPL usually, current IPL does not allow. I think the maximum wavelength which is permitted there is 1200. Okay. So you have to see and be very careful with skin of color.
So we have to be cognizant of the Fitzpatrick skin types for the IPL but yes, maybe not for the fractional CO2. Yes. So now we come on to the most awaited part of this podcast, that is the pearls from your experience of using the laser in the burn scars. How has your experience been in using the lasers for the burn scars? So
we have used the fractional CO2 extensively in our department, and we conducted an RCT 2 years ago, one which was a CO2 fractional laser treatment alone, and the other study arm was the combination of pressure garment and silicone gel. And this was started soon after healing was complete, and 3 settings of laser were done, and 1 month after the last setting, we evaluated results. And we found that the CO2 fractional laser produced maximum benefit in terms of pliability and scar height. And whereas the compression and silicone gel sheeting gave better results in terms of pigmentation and erythema. Although in both groups, we had a statistical significant improvement in both POSAS and VSS scales compared to baseline. So that was the personal study. And based on that, we are trying to use the fractional CO2 laser more.
So how do you decide on which scar should undergo a laser treatment and which patient should undergo a steroid or some other modality of?
So if we have a thick erythematous narrow scar, I would try to inject triamcinolone in those patients and use a silicone gel sheet and compression along with that. If I have thicker scars, thicker means thicker than 2 millimeters, then I would possibly use triamcinolone more likely than CO2 laser. The CO2 laser I will use where the scars are less vascular with more of irregularity, more of stiffness and tightness, where I want pliability more. So there I would prefer the CO2 laser. Very often you end up early, you use steroid and compression, and then later on, once it is settled, then the remaining characteristics you try to improve with the fractional. So it is always a multimodality treatment. Only what to place where is the thing you have to decide.
Right. Once we decide which patient will undergo the laser treatment, what will be the pre-procedure counseling? Would you ask them to apply something or take some sort of care?
So all patients who undergo or are scheduled to undergo a fractional CO2 laser, which is ablative means they break the epidermis, they are put on a very strict sun protection regimen before treatment, and which continues till their treatment is over. And that is no direct exposure to sun and a sunscreen of SPF 50 used 3 times a day. So that is their baseline preparation before laser treatment. And other than that, what you have to ensure is compliance. That you have to tell them that you will do treatments at say maybe 4 to 6 week intervals, and they have to be available for about 5 treatments. That is what we plan before the surgery, before the laser.
Right. Now, once the patient comes to you for the laser treatment, how do you start the first setting in the laser machine? Where do you start? How much power? How much frequency? How do you decide on that?
You can see a screenshot from the screen of the laser machine. They come with preset settings also. You can choose scar remodeling, scar tightening, but we usually don't do that. What we do is we select depth first. And depth of a CO2 laser in different settings from light to medium to deep to very deep varies usually between 50 microns to almost 1200 microns. And that is decided by the thickness of the scar. And we usually start, if the scar, unless the scar is very thick, I keep only level of 1 and 2, which is light and mid depth, 1 and 2. And then second parameter to be decided is the density of the MTZs, the microthermal zones. Like because of fractional CO2, it ablates small cores of tissue with gaps in between so as to preserve the epidermis of the scar. You have to understand that a scar is different from normal skin. A scar does not have appendages from where epidermis can regenerate. You have epidermis and then you have collagen. So you have to leave enough epidermis between the thermal zones so that it can heal quickly. And consequently, scarring reduces. So we don't go very dense. Initially, we keep the density less. On a scale of 1 to 5, I usually start with 3. And then the last parameter to be set is the dwell time. Now, that depends on the delicacy of the scar. If a scar is fresher, I will use maybe 200 microseconds. And if a scar is older, where the erythema is gone, it is mostly a stiff scar, an uneven scar, I will use maybe 400 microseconds.
Dwell time is the exposure time.
Yeah, for the duration which the laser is on.
Okay. Right.
And so we use that, and then it is set on the scanner, and the scanner maps out the area and it treats. So that is how you do your first setting. Subsequently, settings will be guided by the response in the first setting.
So after this procedure, what would you ask the patient to do? the follow-up advice?
So what we do is that we apply a combination of an antibiotic and a topical steroid, like it is like fusidic acid and betamethasone cream, and that we ask them to apply immediately that night and maybe the next morning. I tell them that when the redness and swelling is gone, there is no need to apply any ointment. After that, they only do face wash and moisturizer and sun protection.
So they have to apply that and clean it off in some time, or apply and leave it?
So they apply and leave it,
Yeah.
and then when they wash it the next time, then they apply again.
Okay.
And after the redness is gone, which is usually the next evening, they are only on face wash and moisturizer and sun protection. And I tell them, this is very important, that the first, because this is a common adverse effect, infection, I tell them that for the first 24 hours, they will not use tap water to wash their face. They can use bottled water, they can use RO water, they can use filtered water,
But not tap water.
but not tap water. Atypical mycobacteria
That is
are
important.
ubiquitous in tap water. If cases have been reported, there's a case report from Melbourne, 2 cases after fractional CO2. So there's a very important part of a post-procedure instruction. And 2 other instructions they are given. They have to watch out for those things. One is, how long did the erythema last? And a dry crust, rough crust forms on the scar. When did that come off? The day it came off. So those 2 things the
2 things
patient
to
has
watch
to
for.
patient has to keep track and let you know in the next sitting.
Okay. When would you call them up for follow-up?
So we call them for follow-up only when the next sitting is due, and
Okay.
which is usually 6 weeks.
6 weeks. Okay.
Yeah.
Okay. And you have said how many settings would you want to give in total?
So we usually tell them that we'll need about 5 sittings at least. But after 3 sittings, we take stock of
Okay.
how much improvement has happened in which parameter, so that you can adjust your laser or counsel the patient accordingly.
And in the next setting, would you how do you decide on the settings? Would you keep them same? Do you change something?
So if the patient says that the redness went away that evening only, and that the crust separated in 4 days, then obviously I have the margin to increase the dwell time and the density maybe. And but if they say that it took 7 days for the crust to come off, then my settings are optimum and I cannot afford to increase them further.
Okay. This is a very useful pointer for the clinical practice, I think. So what about the complications that you have seen in your practice?
So
after
one
laser?
complication is delayed healing. That is, if you use too dense a setting and too high a dwell time. And then that is what will cause delayed healing, because you have very little epidermis left between the thermal zones. So that is one. Second is infection, which I have told you about. And the
Don't use
third
tap
is
water.
post-inflammatory hyperpigmentation. Patients who are not careful about sun exposure tend to, they think that if they sit in the veranda, there's no need to use sunscreen if it is cloudy. So you have to be very clear from the beginning that whether it is cloudy or sunny, whether they are indoors or outdoors, they have to use sunscreen 3 times a day and no direct sun on face. That has to be very importantly. Otherwise, you will be left with managing PIH for 6 months.
Okay. Suppose I get a patient with PIH, how do I go about managing it?
So firstly, I know and I tell them that they have not been good with their sun protection. So we have to
I
start
need
with
to
that.
know yes.
Usually we then switch to physical sunscreens. Physical sunscreen means sunscreens which have zinc oxide or titanium oxide.
Those
in them.
that leave the white paste.
Yeah,
on
the
face.
mineral sunscreens.
Okay.
And they are more effective. So we get on to that. And secondly, we start a combination of isotretinoin and hydroquinone, and with a very low concentration of isotretinoin first, 0.0125%, and then gradually go higher and review the patient every 2 weeks.
Okay.
And to see how much of an improvement is going. Again, we don't want to get too strong. You have to understand this. The more injury you cause to the epidermis, the more likely it is to produce pigment. And therefore, we go very mild. We take time, but we go slow. And after about 3 months, we switch from hydroquinone to maybe a vitamin C and kojic acid. Hydroquinone you should not give for a very long time.
Very long. So our next question is, do the lasers help with the scar tightness and the contractures as well?
Yes, like I said earlier, also mild tightness, which is primarily related to some amount of contraction in the early time. Yes, the CO2 fractional laser, since it remodels collagen, it relaxes it, you will get improvement in that. But a contracture CO2 laser cannot improve.
That requires surgery.
Yeah.
So, what is your experience about combining the multiple modalities like steroid, laser, radiotherapy, fat grafting, PRP? There are a lot of things available in the market.
So I have never used radiotherapy. We start with silicone gel sheeting and compression garment, and we keep seeing. At 3 months, we see whether the patient is responding adequately. At 3 months, if we think we need to add something, we add a fractional CO2 laser. Once a fractional CO2 laser is done, we've done 5 settings. And then if any surface irregularities remain, then we may consider doing PRP or nanofat.
This brings us to the end of my list of questions about the lasers. Sir, would you like to add something from your experience of lasers?
So I'll just show you one of the representative cases where patient had burns to one side of the face. We had released all his contractures earlier and grafted him. He had very heterogeneous scars. We dermabraided them and did skin over grafting. And after that, we started him on CO2 fractional laser because everything was still uneven, dyspigmented, stiff, and erythematous in certain areas, hyperpigmented in certain areas. And you can see at the end of treatment, like 5 sittings of lasers, we have a very good color match. We have the leveling of the scar, and the dyschromia has almost disappeared.
So, how long after the surgery was the laser?
So, in this, we started the laser, I think, about 3 months. The picture on the left you can see is 3 months after the grafting, and what you see on the side is after another 5 sittings, that is roughly 6 weeks. So, in 6 months, roughly, it has improved in that.
This is an amazing result.
Yeah.
There's something to learn from.
So I think CO2 fractional laser is an amazing tool. Only you have to select your cases well and have your settings very correctly determined. Your feedback from the patient should be very good. It will help you modify subsequent settings. You have to be very stringent with the patient regarding sun protection and post-procedure care, and evaluate at 3 sittings. If nothing is happening, there is something possibly wrong, either in your parameters or in your selection of the case. So you can review your position then, and we always do that. After 3 sittings, we sit with the patient and review.
Thank you, sir, for sharing your vast experience and knowledge with us for the use of lasers in the burn scars. And I expect that our audience would have also enjoyed this talk and would gain from the same. Thank you so much for spending your time with us. Bye.
Thank you, Raghav. Thank you. It was a pleasure discussing this with you. Thank you.